Welcome to Digital Campus. Today, we're going to spend some time talking about immediate implant in the aesthetic zone. And what are the factors that will make it into a success? What are the factors that will cause the failures? Now, as you know, every time when a patient comes into your office with a front tooth that's failing, seeking for an implant, typically there's only a few ways you can treat it. You either extract the tooth, put some bone graft in there, we call that ridge preservation, wait for 2 to 3 months for the bone and the soft tissue to heal. Subsequently, you open the flap and put an implant in. We typically call that delay implant placement. Now, there's another method. That is, you extract the tooth, you put an implant into the socket right away. We call that immediate implant placement. In fact, some people, besides putting the implant immediately into the socket, they will put a provisional on top of that single implant. We call that immediate tooth replacement. Now, that's what we're going to be focusing on today. Now, if you think about it, implant in the placement in the delay heal sites, we have more than 50 years of experience in it. All right. For immediate implant placement, we have approximately 20 years of experience now. Now, looking at the history, we know that since the incipient of immediate implant placement, people say the advantage of it is you can not only shorten the treatment time, but by putting a provisional onto the implant right away, you can actually maintain the gingival architecture. That means aesthetics. But is it true or not? Well, to be honest, probably around 5-6 years after this procedure has been advocated, we have a lot of clinicians that say you should never do this type of procedure. Why? Because of this type of problems. Well, typically, there are three main things. We know, first of all, we know from an implant success standpoint, immediate implant placement can get good success as long as you can get good stability. But the problem, my friend, is the soft tissue problems, okay? So what are they? For example, a lot of clinicians, after such procedures, they end up getting gingival recession, sometimes discoloration of the gingiva. Now, I want to introduce the term to you is when you look at the patient from an incisal point of view, that means the tooth from an incisal point of view, we want to look at the facial gingival contour changes after such a treatment. For immediate implant placement, if there's any gingival problem that occurs, it's typically one of these three factors. And these factors tend to hold hand in hand with each other. All right. We're going to spend some time talking about predictability. How can we get predictability in gingival aesthetics? Especially since most of the problem is with the facial tissue, and that's what we're going to be focusing on. We're going to spend some time talking about these 5 factors here. Now, for this module, I'm going to split it into 3 lessons. The first lesson, we're going to focus on the thickness of the tissue. Some people call it the gingival biotype. The second lesson, we're going to talk about the bone as well as how you should position an implant into the anterior socket. The last lesson, we're going to talk about every time when we put an implant into the socket, there will be a gap. How are we going to manage the gap? Should we put bone graft in there or not? And last but not least, we'll talk about how will the diameter of the implant you are going to select is going to affect the aesthetic outcome of the treatment. So let's talk about lesson number 1. What are the learning objectives when we look at thickness? That means thickness of the gingival biotype. Well, there are 3 things we're going to be talking about. First of all, what happens when the gingiva is thin? What are some of the drawbacks that we have upon surgical and restorative insult? Second thing is, how do we define gingival thickness and how do we evaluate them as a clinician? Last but not least, let's say if the gingiva is thin, if you put a piece of soft tissue, connective tissue graft underneath there, will that increase the thickness of the tissue? Okay, will it benefit the overall treatment scheme there? To evaluate gingival thickness is a very subjective matter, as you know. Typically, what I like to do is take a periodontal probe the sulcus, and gently lift the probe towards me facially. Now, if I can see the vague outline of that probe shining through underneath that gingiva, what that typically tells me is, you know what, the gingiva is on the thinner side. All right, so what is the problem of thin gingiva? To be honest, when we look at the literature, both from a restorative or natural teeth as well as implant, there's not a lot of scientific evidence based on what will happen upon surgical and restorative insults on thin gingiva. This is one of the articles that I can share with you. This 2011 articles, what they did is they look at prospectively a series of implants that were placed immediately in the aesthetic zone, immediate tooth replacement that is. And then 4 to 8 years later, what happened? Now, I'm going to just isolate one part of the study to show you. What they did in this article is they separate their group of patients into thick and thin gingival biotype. That means after immediate tooth replacement on thick and thin gingiva, what will happen to the gingival recession? If you look at the data, very interesting. The group that is with the thin gingiva, it has significantly more facial tissue recession than compared to the thick tissue. So basically what we know is this: thin gingiva tends to be kind of like our enemies as a dentist, because upon surgical and restorative insult, thin gingiva have a high propensity of gingival recession. All right. Now, let's spend a minute talk about what is thick and what is thin. When we look at the literature, this is the number I got. I summarized all the articles that look at, that during the study they evaluate gingival thickness of teeth in the aesthetic zone. Interestingly enough, gingival thickness in the aesthetic zones, actually the range is very small, between 0.7 to 1.5. Now, the next question we need to ask ourselves is this: how then do we quantify what is thick and thin then? There's not a lot of information in the literature. And in 2008, I took the liberty to just say, well, I'm going to just draw the line right between 0.7 and 1.5, and it comes down to be around 1.1. And for the sake of my own education, I say anything greater than 1.1, I call that thick. Anything less than 1.1, I will consider that as the thinner side. And with this set of information, I put forth a series of research just to analyze what is thick and what is thin. This article published in 2010 in the International Journal of Peri-Restorative Dentists. And what they did is, the authors did is they try to look at the different methods in evaluating gingival thickness of teeth in the aesthetic zone. And in that study, what they did is they compared 3 methods: visualization, utilizing the probe, and using what you call direct measurements. All right? And the study of the design is actually very simple. All this patient with a failing maxillary anterior tooth. Now, before the extraction, we first of all utilize visualization. That means looking at the gingiva to define thick or thin. Afterwards, we take a periodontal probe the sulcus, and then to see whether we can see the probe again. Again, if you can see the probe, that means thin. Don't see the probe, that means on the thicker side. Last but not least, after extraction of the failing tooth, immediately afterwards, we take a tension-free caliper to measure the facial gingival thickness approximately 2 millimeters apical from the free gingival margin. By doing so, we got some interesting data. First of all, if you base on 48 sample size, we noticed that when you look at the measurements of the gingival thickness through direct measurements, interestingly enough, it is between that 0.7 to 1.5 range there. In fact, it is this next set of data that surprised me the most. What we see is this: when you look at V means visualization, P means probing, and M means direct measurements. When we look at VT does not equivalent to PT at 23% of the time, what that means is this: when we look at the patients visually, the gingiva, and it tells on the thin side, on the thick side, when we put a probe in there, 1/4 of the time, we actually can see the probe. So what does that mean? If you look at all this data there, the different methods, they don't really correspond with each other very well. This is the key point to bring home, ladies and gentlemen. Visualization to evaluate gingival thickness is not very accurate. The best way, obviously, is through direct measurement, but that tends to be invasive. So the next best thing is actually based on the study data is utilizing the probe. Because the probe will fast approach the way that you can evaluate gingiva just like that direct measurements. In fact, if in doubt, we should always approach the case as if it is like a thin gingiva, and we should use what you call perioplastic surgery. Now, the next question is, if the gingiva is on the thinner side, what happens if we take a piece of soft tissue graft and graft it underneath there? Will that thicken up the gingiva, such as biotype conversion? The second portion of this article tried to address that, which was published in 2012. The design of the study is we have two groups of patients. Both of them, we did immediate tooth replacement in the aesthetic zone. One group, after the implant placed, no tissue graft. The second group, after implant placed, we put a subepithelial connective tissue graft on top, underneath of the implant, underneath the gingival, underneath the soft tissue. Let's take a look at the data here. Now, right after extraction or for the patient in this study, we take a tension-free caliper to measure the facial gingival thickness. Approximately 1 year later, with or without the tissue graft, again, before we deliver the final crown, we utilize that tension-free caliper to measure the facial gingival thickness once again. Let's look at the data here. Well, you can see the sample size and the thickness of the facial gingiva at surgery. Interestingly enough, and not surprising, is around 1.1 millimeters. Now, let's look at what happens approximately 1 year later. This is what we see. First of all, let's look at the no connective tissue graft. It's say 1.4 millimeters. Interesting, right? Without tissue graft, 1 year later, the soft tissue actually becomes thicker. Why is that? This is what we notice. The facial implant gingiva can be thickened, even without tissue graft, providing if the implants and the prosthetics are placed slightly palatal to the implant to the extraction socket there. When we look at this group with the soft tissue graft, we notice that it had become thickened, become 2.6 millimeters. So what we learn is this. When we do tissue graft at the time of implant placement, it can effectively thicken up the soft tissue, at least at a short-term basis. Now, what I did here is this. I summarizes all the publications that I can find from the literature, from the PubMed, that did any facial tissue measurements of the extraction sites and then also at the implant placement with or without tissue graft. When you look at the data, they are very similar or comparable to the data that I just showed you. All right? So once again, interesting, remember that. Without tissue graft, as long as the implants are placed palatally and the prosthetic abutment and the crown are slightly palatal to the original facial gingival position, the soft tissue tends to become slightly thickened by its own. By putting a soft tissue graft in front of the implant, during the surgery, you'll find out that actually it can effectively thicken up the soft tissue. All right, now why is this soft tissue graft even important? Maybe remember, I want you to remember that 1.4 millimeters and 2.6 millimeters that were shown on the last article there. Why is this significant? I believe this article tend to kind of give you the idea why is it important. Ronnie Young and Hammerley published this back in 2007. And what they did is they tried to look at how thick of a soft tissue, gingival tissue, does it take to mask various types of restorative materials. The design of the study actually very simple. On the pig jaw, what they did is, first of all, they created 4 different types of restorative material, made with 4 different discs. You have a titanium. The second disc is titanium. On top of it, they put some porcelain on it. The third disc is make up zirconia. The fourth one is on top of the zirconia, they put some porcelain on it. So now you have these 4 discs. To create 3 different types of gingival thickness on top of this, they basically utilizes soft tissue harvests from the palate, and then they put it on top of the disc. To evaluate color changes over these 4 discs, what they use this thing called a spectrophotometer to evaluate color change. And the unit for that is delta E. Now, what I did is I summarized that data onto this graph for you to take a look. Let me explain to you. You see the 4 different types of restorative material at the bottom: titanium plus zirconium, zirconia, and zirconia on top of it as ceramics. Now you can see the 3 different bars there. Blue represents 1.5 millimeters of gingival thickness. Gray represents 2 millimeters, and yellow represents 3 millimeters. So there's one thing that's missing on this graph there. It is the delta E for human beings. What that means is for a young human beings with good eyesight, the delta E is around 3.7. So when you look at that, anything above that line there, that tells you that there's a discoloration change. All right, so how does that affect our thinking process? All right, interesting enough, if you look at it, when the gingival thickness is 3 millimeters, you cannot see any discolorations, regardless what type of restorative material you put underneath there. When you put 2 millimeters, you'll find out that you will only see the titanium group, but the zirconia group, you don't see anything. Now, when we use 1.5 millimeters, you actually see discoloration in all 4 groups. More so in the titanium group, less so in the zirconia group. All right, so what does that mean? Well, remember I told you 1.4 and 2.6 millimeters. 1.4 is without tissue graft, 2.6 is with tissue graft. All right, when you look at this data, you know what? Well, I think the answer of whether is there any benefit of putting soft tissue graft at the time of implants to minimize soft tissue problems, I think the answer is very clear. All right? When we do tissue graft, at least from a short-term basis, it will thicken up the soft tissue. Put aside anything, at least it will minimize discoloration. All right. Now, what else can doing soft tissue graft be beneficial to the equation here? Well, first of all, there are 2 ways we can do the tissue graft at the time of implant placement. We can either, what you call do a bilaminar technique, do a tunneling, and we tunnel the tissue graft in there, or you can raise the flap and put that tissue graft in there. The second method that people use is what they call the scarf technique, kind of like creating like a band of soft tissue and just put it underneath the sulcus, of where you place the implant. Any benefits of doing soft tissue graft? Well, this article published in 2009 tried to address that. What they did is, on anterior cases, we did immediate implant placement. In fact, immediate tooth replacement, based on 20 sample size. What they did is they look at gingival recession over time. Now, this is a 2-year study. Interestingly enough, at 2 years, none of these cases actually exhibit facial gingival recession. So that at least suggests to us is, if the implants are placed correctly and you did everything correctly, with tissue graft, it can potentially help to increase the tissue thickness, make it more resilient to tissue recession. Now, I want to show you one more article. This is a randomized prospectively clinical trial. What the authors here did is this. On patients that need anterior immediate tooth replacement, they after the surgery, what they did is they separate the patients into 2 groups. One group without tissue graft, and the second group with tissue graft. Well, let's take a look at what they did find out. What they find out is this. The group with soft tissue graft, it has significantly less facial tissue recession. So once again, this is what we learned about thickness, gingival biotype, gingival thickness. The key is, first of all, to evaluate gingival thickness, the period probe is more effective than visualization. On top of that, thin gingiva is kind of like our enemy as a dentist because upon surgical and or restorative insults, it will increase the risk of gingival recession. Last but not least, on patients that have thin gingiva, I believe subepithelial connective tissue graft will be beneficial. Not only, it will, in a short-term basis, thicken up the facial soft tissue to make it more resilient to gingival recession. Moreover, it may help you as a clinician to mask the restorative material that you're going to use to restore that implant there. Thank you.